All right, fantastic. So thanks everyone for joining us. So again, welcome to the Peripartum Athlete Musculoskeletal Care Before, During, and After Pregnancy. This is part of the NYU Langone Orthopedic webinar series, and this one is sponsored by the Center for Women's Sports Health. And so with no further ado, I just wanted to start by introducing in a little bit more detail our speakers for the evening. So my co-course director is Dr. Elizabeth Barchi, who is a clinical assistant professor in the Division of Primary Care Sports Medicine and a physician for the Harkness Center for Dance Injuries, and she'll be speaking tonight. Her talk is entitled Preparing for an Athletic Pregnancy. I'm who's talking now, so Dr. Carter. I'm a clinical associate professor. I'm trained in pediatric orthopedics and sports medicine, and I'm the director for the Center for Women's Sports Health here at NYU Langone. And I'll be speaking just briefly about sports and fertility. The next two speakers after that are Dr. Lauren Borowski, a clinical assistant professor in the Division of Primary Care Sports Medicine, also a physician at the Harkness Center for Dance Injuries. She'll be speaking about pregnancy-related musculoskeletal conditions. Dr. Julie Hahn, a clinical assistant professor in the Division of Primary Care Sports Medicine and a figure skating aficionado, will be talking about sports and physical activity during pregnancy. And then finally, and I think this is a real highlight of the course tonight, we've asked Heather Heineman, a doctor of physical therapy and an orthopedic clinical specialist, the assistant supervisor of physical therapy at the Harkness Center for Dance Injuries. She's been working with the New York dance population for 8 years and is a trained provider of pelvic floor physical therapy. She and her partner tonight, Dr. Rebecca Kesting, also a doctor of physical therapy and orthopedic clinical specialist, also specifically trained in pelvic floor therapy, and they'll be sharing pearls with us for understanding and rehabilitating the pelvic floor. Before I actually get started, I wanted to give a little bit of background about this course, and I just wanted to with a couple of details. So first, when we think about women and pregnancy, what do we know? Well, women comprise more than 50% of the U.S. population, in fact, about 50.8% from recent census data. So this means that there are more than 75 million women of childbearing age, and this, I've listed here 15 to 50 years. This may be quoted variably, but somewhere in that range in the United States. And almost 60% of these women, so more than 44 million women in the United States, are mothers. And so what this means is that the chances are that someone you know is, was, wants to be, or will be pregnant at some point in her life. So what we're talking about tonight is relevant. What we know about women in sports, well, since the introduction of Title IX back in 1972 that ensured equal access for participants in all federally funded programs or activities, and these include sports, that the number of girls and women who participate in sports has gone from 1 in 27 to 2 in 5. So from about 4% to more like 40%. We've seen a 990% increase in girls participating in high school sports, a 545% increase in girls and women participating in college sports. And when we look at some of the most common sports, like when we look at the data from USA Soccer, more than almost 2 million girls in the U.S. are affiliated with USA Soccer, and almost 500,000 girls in the U.S. play high school basketball or volleyball. And so the chances are that someone you know is, was, wants to be, or will be athletic at some point in her life. But despite this, very little is known about the risks and benefits of participation in sports and other physical activities during the childbearing years, and these may span as many as 4 decades. And so the chances are that someone you know is, was, or will be given information about athletics and pregnancy that is based on expert opinion rather than scientifically acquired data. And I don't want to belabor this, but there's a good reason for this, and it's research. It's protectionism in research. So after World War II, a code of ethics was drawn up that outlined the moral, ethical, and legal requirements for conducting research with human subjects. And the basic tenet was that the protection of human subjects was of paramount importance. And pregnant women and their fetuses are identified as a particularly vulnerable population that needed protection. And so these were excluded from participating in biomedical research. And then this exclusion was broadly applied to include any premenopausal female who was capable of becoming pregnant. And then our experience as a community with thalidomide, which was introduced in Germany in 1957, only heightened our aversion to involving women of childbearing age in biomedical research. And I've shown a picture here of 2 children exposed to thalidomide in utero who ended up with phocomelia. And so the point of this is that the chances are that someone you know is, was, or will be given information regarding athletics and pregnancy that stems from a collective desire to protect the vulnerable populations and not from the results of biomedical research. And so, however, this protectionist counseling about sports participation in pregnancy may actually have negative secondary effects, right? It may preclude women from actually being able to tap into the myriad benefits of participation in sports and physical activities, and these include bone health, cardiovascular health, protection against diabetes and development of metabolic syndrome, mental and emotional health, as well as academic performance. And for elite women athletes, actually not being able to participate in their sport may result in loss of identity, income, or even career. Recently, however, there have been several, and I've shown several of them here, examples of pregnant women who are giving elite athletic performances without any negative consequences for themselves or their children. And you see here Carrie Walsh-Jennings, who won an Olympic gold in beach volleyball, Serena Williams, who won the Australian Open, also while pregnant. We have Kara Goucher, who is like the pregnant marathoner. And so I think we have to ask ourselves, do we have to move the bar in terms of what we're able to expect pregnant women can do in terms of physical activity and sports participation? And I would argue that at the very least, we have to change the conversation. And I think, and that's really the genesis of this webinar, is that I think a lot of the medical care that pregnant women undergo is sort of siloed, and sports medicine providers and OBGYNs and physical therapists and all of us can do, I think, a better job of talking to each other so that we can better care for women who want to be athletic and want to be successfully competitive during and after pregnancy. And so with that, again, let me welcome you to the webinar, and then we can move on, I think, to the first talk. Can you pull up the next slide, please? Thank you. Super. Okay, so I'll start. This talk is actually pretty brief, and that is on purpose, and because I wanted to leave some time for all the rest of our presenters to talk about really, I think, some of the meat, the meat of the conversation. So again, this is our webinar. I'm going to be talking now about sports and fertility. I have no disclosures related to this talk. And so the brief outline for this talk is, first we'll talk a little bit about preconception care, some fertility considerations for athletes, meaning pregnancy planning to accommodate training and competition, the risks for infertility due to sports-related injury or illness, and specifically relative energy deficiency in sport, and then the risk of miscarriage and preterm birth. So what is preconception care? It may be defined as a holistic approach to care for women of childbearing age that aims to reduce and prevent adverse pregnancy-related outcomes by identifying and modifying medical, behavioral, and social risks prior to conception. This may include things like a physical assessment. So this could include a BMI, maybe lab panels in an athlete. You may be looking at things like iron or iron deficiency, and certainly a menstrual history. It includes a risk assessment. Again, in an athlete, you may be asking specifically about eating disorder. We know that maternal pre-pregnancy underweight is a risk factor for preterm birth and small for gestational age infants. The third part of preconception care is vaccination. And while typically this is talking about things like, flu and measles, I would also add that for athletes who typically will do a lot of travel for competition, that maybe we want to think about incorporating travel vaccinations as well. And then finally, the fourth component is counseling. And while this is tailored certainly to the individual, if you're counseling an athlete who is potentially thinking about or has the ability to become pregnant, maybe you're going to think specifically about asking them about supplements they're taking so that you ensure that they're being compliant with Anti-Doping Association, and then also specifically about family planning and maybe, as I'll touch upon in a minute, family planning related to competition, maybe how to plan around it. so thinking about the fertility considerations, and I've termed this slide delayed or strategic conception. So the point of this is that elite female athletes may train and compete, in fact, well into their 30s. So this period of training and competition coincides with prime childbearing years. And so increasingly, athletes may desire to have children and then even return to competition after childbirth. And so I think the important fact here for us as providers is that athletes should be potentially counseled about strategic planning and thinking about strategic planning for conception and pregnancy that might be minimally disruptive to a competition schedule. And then also, athletes may be counseled about strategic fertility preservation, and maybe they'll elect to for egg harvest and then cryostorage of gametes and or embryos for use in retirement. The next thing I wanted to touch upon was eating disorders, as this is one of the few things that has been identified as a risk factor for problems with pregnancy and gestation. And this is specifically relevant to athletes because athletes do have higher rates of eating disorders than non-athletes. So athletes who seem to be most affected, as you may know, are those who participate in endurance sports, athletic sports, or sports that have weight categories. Other risk factors may include things like early sport-specific training, overtraining, a history of injury, a pressure to lose weight, or negative sport culture, or even negative or inappropriate coaching behavior. And again, as I mentioned, this is important because pre-pregnancy underweight is associated with preterm birth and low birth weight babies. And so identifying athletes who may have an eating disorder is important for counseling and treatment to improve outcomes both of pregnancy or pregnancy for both the woman athlete as well as her children. I wanted to mention RED-S, and as this sort of goes hand in hand with eating disorders. So RED-S stands for Relative Energy Deficiency in Sport. It's the newer term that has typically replaced the use of the female athlete triad, both because we understand it's not just a triad, but also that because it doesn't just affect women. It may be defined as impaired physiologic function resulting from relative energy deficiency, such that the body cannot function optimally for maintenance of health and peak athletic performance. And so this may manifest as menstrual dysfunction. And I love this. I put all the citations at the bottom of the slides, but I sort of love this idea of menstrual dysfunction confounding conception. This means either women with relative energy deficiency in sport may have problems with infertility, but also they may end up with unexpected pregnancies or misdated pregnancies because of the hormonal disruptions. And then we see the typical things like bone health impairment or bone stress injury, potentially even impaired immunity, impaired cardiovascular health, disruptions in metabolic rate, and so on and so on. So RED-S is now something that is recognized to affect multiple body systems and certainly a woman's ability to become and remain pregnant and maintain a healthy pregnancy. There's very little data when we look at fertility and athletes. This is one recent study that has come out that provides at least a little bit of data to help us, guide patients make, I think, data-driven decisions related to fertility. And so these authors devised a novel survey, and then they gave the survey to athletes as well as doing structured interviews with them. They identified 34 elite Norwegian female athletes, and then they paired them with 34 active controls. And when I say elite, I mean these were truly elite athletes. Amongst them, they had garnered 292 international medals in competition and 36 at the Olympic Games. These were the stats that they ran. And then the results of this were, in fact, that there was no significant difference between the elite athletes and the non-athletes regarding infertility. In fact, one of the controls, but none of the athletes reported this. 2 athletes did report IVF usage, and none of the controls. In fact, this wasn't for fertility preservation, as you might have inferred, but actually because these were women who were in same-sex relationships trying to get pregnant. And then there was no difference between things like miscarriage, preterm labor and delivery, or low birth weight. And so the conclusions from this study were that elite athletes and active controls get pregnant easily and deliver healthy babies. And so in summary, just starting to think about this topic, I would say that preconception care should be tailored for athletes, that counseling regarding strategic family planning and fertility preservation may be useful for athletes who are planning to compete into their 30s and beyond, that fertility and pregnancy outcomes may be affected by the presence of an eating disorder, and these are more common in athletes, that overuse, overtraining, and underfueling syndromes, and Red S is the example of one, may negatively affect fertility through disruptions in the neuroendocrine axis. And finally, there are no robust data to suggest that athletes and even elite athletes suffer from infertility and fertility-related complications at higher rates than non-athletes. Thank you.
All right. Thank you, Dr. Carter. That was an awesome talk. Now you have me, Dr. Elizabeth Barchi, here speaking to you from the command center. So for the next couple of minutes, we'll talk about preparing for an athletic pregnancy. So a lot of this is going to be a little bit like thought experiments. Unfortunately, I have no disclosures. So let's talk about why. Why do we want to be active during pregnancy? Well, maybe you're thinking to yourself, I've never been active in my life. Why should I start now? I'm about to be pregnant. It's a really great question. And so some of the many benefits, and Dr. Hahn is going to go through this as well, being active, being athletic during pregnancy helps improve your cardiorespiratory fitness, so it's less difficult to walk up the stairs, reduces the risk of obesity, which is a real risk during pregnancy. It reduces the risk of gestational diabetes, and it also enhances your psychological well-being. Moving really feels good, and sometimes it can be tough when you're pregnant to stay moving because you don't feel as well. So being very active can really help enhance your mood throughout pregnancy. There we go. Some of the goals of exercise during pregnancy. So you want to be shooting for a more moderate intensity exercise. We're not going super intense, but we want to get that heart rate moving. You want to shoot for at least 20 to 30 minutes most days per week. And of course, throughout this whole time, be in touch with your doctor because you guys may need to make some adjustments based on how things are going. And that's an ongoing conversation, and just because you make certain changes doesn't mean that they're permanent. You can always be fluid about it. Some of your other goals, remember, this is more for well-being and overall health. During pregnancy, we should not be focusing on reaching peak fitness goals because that's just a little bit unrealistic, or training for athletic competition. Although we do have elite athletes who do compete while pregnant, but it's also a time to just think about taking care of yourself and not necessarily trying to achieve things out of the ordinary. Make sure you're focusing on activities that are minimizing the risk of loss of balance and fetal trauma. So, martial arts during this time, especially after the first trimester, might not be the best form of activity. And then, of course, it's important to remember that adverse pregnancy or neonatal outcomes are not increased by exercise. So what, a lot of women were told back in the day, we've just found is not correct. I do want to put in a plug for our pelvic floor specialist who will be talking later. The earlier you start these pelvic floor exercises, the better the outcome. So they'll talk about, Heather and Becca will talk about that a bit more. So we talk a lot about what we shouldn't do, but I figured I'd spend a minute talking about other things that we can do. So during pregnancy, swimming and water aerobics are really wonderful exercises. They help you feel a little bit weightless, take some of the pressure off. Zumba and traditional aerobic classes, very fun. Rowing and jogging, those are all safe and appropriate exercises. There's hiking as well. And then also stationary and spin classes. You'll notice a theme. All of them are, pretty stationary. They're not relying too much on balance, and they're not contact activities where you might be posing a risk to the fetus or the mom. Some other forms of strength training, Pilates. Dr. Hahn will go into more about some of the specifics of these guys. Dance classes. I always have to put in a plug for dance. Free body weight based strength training, and then also free weights and machines. But the one thing to be careful about these things, even if you weren't pregnant, I'd still tell you the same thing. Always use a spotter to prevent injury. I've had a lot of athletes, everyday athletes, come in with injuries from issues with the machine hitting them, and they get an injury from that. So make sure that you're always remembering to have safety first. That's the most important thing when you're exercising during pregnancy, to avoid trauma to yourself and also to the baby. And with that, I'm going to turn things over to Dr. Julie Hahn, who's going to be talking to us about sports and physical activity during pregnancy, so a little bit more in depth.
Okay, thanks for that introduction. So again, I'm Dr. Hahn. I'll be talking to you guys about sports and physical activity in pregnancy. So we know that regular exercise has significant benefits for health and wellness for all people, and specifically the American College of Obstetrics and Gynecology advise all healthy pregnant women should engage in exercise. We know that exercise is safe and beneficial for most pregnant women and their fetuses. There are expert guidelines and recommendations regarding exercise during pregnancy. The ACSM position standard on exercise states that the scientific evidence demonstrating the beneficial effects of exercise is indisputable, and the benefits of exercise outweigh the risks in most adults. It goes on to advise continuing an existing exercise program or initiating a regular exercise program during pregnancy. Additionally, the ACOG committee opinion also states that physical activity in pregnancy has minimal risks and has been shown to benefit most women, but some modification, which we'll talk about, to exercise routines may be necessary because of normal anatomic and physiologic changes in pregnancy, as well as some fetal requirements. So women with uncomplicated pregnancy should engage in aerobic and strength conditioning exercises before, during, and after pregnancy. There are numerous health benefits associated with exercise during pregnancy, and this includes improving, maintaining fitness, the maintenance of healthy weight gain during pregnancy, decreasing gestational hypertension, reducing back pain, shortening the duration of labor, and reducing the risk for a cesarean section. The available scientific literature is pretty variable in what it explores and the strength of its findings, but what we'll do today is to review the current evidence regarding these benefits of exercise during pregnancy. So the first benefit that we'll discuss is that exercise in pregnancy can improve or maintain fitness. This 2006 Cochrane review looked at 14 controlled trials of exercise in pregnancy and found that pregnant women who exercised at least 2 to 3 times per week either improved or were able to maintain their fitness level. Price et al. Performed a small randomized controlled trial of sedentary pregnant women who underwent supervised aerobic training for 45 to 60 minutes at a moderate intensity of 4 days a week, and they found that there was increased aerobic fitness and strength in the exercise group compared to the control group, and there was no difference in pregnancy outcomes. Next, another benefit of exercise during pregnancy is that it can maintain healthy weight gain in pregnancy. This 2006 Cochrane review evaluated randomized controlled trials of diet and exercise interventions and its effect on gestational weight gain. And what they found was that women who received the exercise interventions were more likely to have low gestational weight gain than the control subjects who did not exercise. Damjaz et al. In 2014 conducted a meta-analysis of randomized controlled trials, which also showed very similar findings of reduced maternal weight gain in those undergoing structured exercise programs. The next benefit of exercise in pregnancy is decreased gestational hypertension. The same Cochrane review actually found that there was actually no significant difference in the development of preeclampsia between the exercise and non-exercise group. However, there does seem to be this dose response, as this 2014 meta-analysis found that increasing levels of physical activity before and during pregnancy is inversely associated with the development of preeclampsia. So the more women exercise before and during their pregnancy, the less likely they would develop preeclampsia. Overall, there seems to be a mixed quality evidence from which to draw these conclusions, but there seems to be a possible association between exercising and a decreased risk of hypertensive disorders of pregnancy. Back pain is a very common complaint in pregnancy, as a survey of 950 pregnant women showed that 68.5% of women who were pregnant reported low back pain. So this is a very common complaint, and exercise in pregnancy does seem to help reduce back pain in pregnancy. Many studies have shown this. This 2015 systematic review of RCTs found that any land-based exercise was associated with a significant reduction in back pain and also had an improvement in functional disability scores. Also, exercise during pregnancy also seems to have a benefit of shortening labor. A 2016 randomized controlled trial, this was conducted in Spain, evaluated a prescribed exercise program and its effect on pregnancy outcomes. What they found was that there was a significant reduction in the first stage of labor among the women who were prescribed an exercise program compared with the control group who did not have any exercise. Lastly, there are many studies which demonstrate that women who participated in a structured physical exercise program were less likely to require cesarean delivery than women who did not participate in such programs. So if exercise has so many benefits in pregnancy, what are the recommended types of exercise? Dr. Barchi touched on this earlier, and the American College of Obstetrics and Gynecology has provided specific guidance on exercise activities that are considered safe. These activities include walking, swimming, cycling, low-impact aerobics, yoga, and Pilates. The thing to note with yoga and Pilates is that you should avoid supine positions that could potentially cause hypotension. Running, jogging, strength training are all considered safe exercise to perform in pregnancy. Racket sports are also acceptable, but you should be cautious to avoid any activity with an increased risk of any abrupt loss of balance and increased risk of falls. In terms of exercise guidelines, years ago, some experts recommended a heart rate of no more than 140 beats per minute for exercise during pregnancy. However, this is outdated. This no longer is the case because there actually can be some blunted and even normal heart rate responses to exercise in pregnant women. The most up-to-date recommendations for exercise is that pregnant women should accumulate at least 150 minutes of moderate intensity physical activity each week. Moderate intensity is the equivalent of 3 to 6 METs. This is usually equivalent to brisk walking, or you can use a rating of perceived exertion, which should be around 13 and 14, which means that exercise is somewhat hard. That seems to be kind of a generic rule, so another test that you can use is the talk test. So as long as you can carry a conversation while you're exercising, you're likely not overexerting yourself. Physical activity should be accumulated over a minimum of 3 days per week. However, being active every day is encouraged. And pregnant women who habitually engage in vigorous intensity aerobic activity or are elite athletes who are highly active, as we mentioned already, they can continue their physical activity during their pregnancy as long as they remain healthy, don't have any pregnancy complications, and discuss with their healthcare providers about how and when their physical activity should be adjusted over time. And vigorous intensity would be the equivalent of running or jogging. And it's important that pregnant women should incorporate a variety of exercise, including aerobics and resistance training, to have greater benefits. what kind of exercises should pregnant women avoid? These are kind of common sense, but you should avoid contact sports due to risk of trauma, and also activities with risk of falls or trauma, so things such as skiing, water skiing, surfing, off-road cycling, horseback riding, and gymnastics. Pregnant women should also avoid scuba diving, skydiving, and hot yoga as well. There are contraindications to exercising in pregnancy that one should be aware of, and you can kind of take a look at this list yourself. What you'll see is that many of these listed include poorly controlled baseline medical conditions, any underlying cardiac and lung conditions, and of course if you develop any complications of pregnancy. Some warning signs which could point to any of those contraindications and conditions listed in the slide previously include vaginal bleeding, regular painful contractions during your exercise, amniotic fluid leakage, having shortness of breath before even starting your exercise activity, any dizziness, headache, chest pain, weakness, calf pain, and calf swelling during exercise. Any of these warning signs, you should stop exercising and get evaluated by a healthcare provider. So next, what are the effects of maternal exercise on the fetus? 2015 meta-analysis reviewed some randomized controlled trials in pregnant women comparing a supervised exercise program with a group receiving usual prenatal care, and this group included 36 trials. What they found was that pregnant women who exercised were less likely to have a large for gestational age newborn, with no change in the likelihood of having a small for gestational age newborn. Mean weight gain in pregnancy was less among those who participated in the exercise program. So the best available evidence seemed to suggest that moderate intensity exercise during pregnancy does not adversely affect infant weight at birth. Next, a recent meta-analysis of exercise programs during pregnancy evaluated studies of aerobic exercise for anywhere from 35 to 90 minutes, which was performed 3 to 4 times a week, and found that there was no significant difference in the rate of preterm birth for women who exercised compared to those who did not. Gestational age at delivery was similar between the two groups, and there was no significant difference in low birth weight babies or in mean infant weight at delivery between the two groups. So the studies conclude that moderate intensity exercise does not seem to increase the risk of preterm birth or earlier delivery. Last, we'll discuss high-performance exercise during pregnancy. The most well-known example of a professional athlete who competed during pregnancy is Serena Williams. She won the 2017 Australian Open during her first trimester of pregnancy, and 7-time U.S. 800-meter champion Alicia Montano ran the 800 meters at the 2017 USA Track and Field Outdoor Championships while she was 4 months pregnant. And the ACOG guidelines do state that it is safe for pregnant women who are already doing vigorous intensity aerobic activity to continue to be highly active during their pregnancy. The added precaution is that pregnant elite athletes need physician supervision to ensure that there's a safe progression of their exercise during their pregnancy. At the same time as healthcare providers, providing advice to elite athletes during pregnancy is challenging because, for one, there's no uniform agreement and definition of what an elite athlete is. It's also difficult to define and measure the degree of exertion, and there are only a few low-level studies of pregnant elite athletes. This is one of the few studies looking at high-performing pregnant athletes, which was published in the British Journal of Sports Medicine in 2012. It looked at 6 Olympic-level pregnant women who were studied at 23 to 29 weeks of gestation on a treadmill exercise activity at approximately 60 to 90% of maximal oxygen consumption. They found that fetal heart rate was within the normal range as long as the mother exercised less than 90% of maximal maternal heart rate. In some instances, when the maternal heart rate exceeded that of 90%, there was a reduction in uterine volume blood flow and subsequent fetal heart rate decelerations. Overall, they did state that all the fetuses did well, and what they concluded was that perhaps exercise at less than 90% of maximal maternal heart rate might be regarded as the safety zone for elite athletes. So for high-performing elite athletes, clinicians and healthcare providers should counsel them regarding exercise during pregnancy to include advice about limitations to maximum exertion, precautions to minimize any risk of injury, and vigilance for potential indicators of overexertion. These are some risks and corresponding guidelines to consider when you're discussing exercise with an elite athlete who is pregnant and if they want to continue exercising at their high levels. Many of these listed risks and guidelines are basically a reprise of the warning signs to discontinue exercise in pregnancy that I discussed in several slides previously. So in summary, regular exercise is recommended for healthy pregnant women, and even those who are not previously physically active can start a new exercise program gradually during their pregnancy. Regular exercise during pregnancy does promote overall wellness and helps maintain appropriate gestational weight gain and even appropriate fetal weight gain. Exercise may reduce hypertensive disorders of pregnancy as well as gestational diabetes and may be associated with a shorter labor and decrease your risk of cesarean section. And elite athletes can continue to be highly active but may need some modifications. Thank you.
Okay, and as Tyler switches over the slides here, I am Lauren Borowski, and I'm going to be talking today about pregnancy-related musculoskeletal conditions. So these are just going to be some of the conditions that can occur as related to pregnancy. There are many others, but these tend to be the ones that come up probably most frequently. So we know after listening to the last couple of talks and general knowledge that there's a lot of hormonal changes that people go through during pregnancy that increase estrogen and progesterone and relaxin as well as prolactin, and all of these can play a role on the musculoskeletal system. And here are just some of the ways that I've listed that can lead to musculoskeletal problems. So the gravid uterus changes the center of gravity, which can lead to some low back pain. There's joint laxity and hypermobility that can potentially cause some issues with pubic symphysis diastasis that we'll go over, along with some other pelvic girdle pain like SI joint pain. The abdominal muscles in pregnancy get stretched to their limit and can lead to widening and diastasis recti abdominis. There's also a lot of fluid retention that happens during pregnancy, which can lead to soft tissue edema and then go on to some nerve entrapment symptoms like carpal tunnel. So first we'll start with low back pain. Low back pain is very prevalent in pregnancy. About 50 to 75% of women will experience some sort of low back pain. And almost all, 94% or so, will go on to have back pain in future pregnancies if they had one in a previous one. An interesting statistic that I had found while doing some of this research was about almost 20% of women will actually avoid additional pregnancies out of fear of having the severe low back pain again. And listed here are just some risk factors for low back pain. So having back pain prior to a pregnancy, having had a back pain in a previous pregnancy, weight gain during pregnancy. There is some mixed evidence on this, but there was a recent study actually published this month in Spine that looked at the degree of weight gain during pregnancy. And for those women who gained over 15 kilograms, which is slightly more than the recommended amount of 25 to 35 pounds for those starting out at a normal BMI, it can increase the incidence of low back pain. And then also some low work satisfaction and poor endurance strength of the low back muscles can increase low back pain as well. So why does it happen? It's really multifactorial. There is some increased lordosis of the lumbar spine, which with some compensatory anterior rotation of the pelvis, along with some pelvic ligamentous laxity. And this leads to what's called a lower cross syndrome, where you have shortening of hip flexors and lumbar paraspinal musculature, along with lengthening and weakness of the abdominals and the glutes. So how does it present? It is often insidious and usually just involves the lower back, but there can be some radiation into the legs, some symptoms of sciatica due to disc herniations. And just as in the non-pregnant patient, you want to make sure that you're also asking these women about red flags that could be indicative of a more neurologic emergency, like cauda equina syndrome. So things like bowel and bladder dysfunction, and saddle anesthesia, so paresthesias in the genital region. Really, there's not a lot of imaging that we want to get done in these patients unless they have these neurological red flags. But if you are going to get some imaging, MRI is the imaging of choice. In terms of treatments, so there was a Cochrane database review in 2015 that showed low quality evidence that exercise may reduce pregnancy-related low back pain, but moderate to low quality evidence suggesting that exercise improves functional disability and reduces sick leave more than usual prenatal care. So what this is really saying is that people go on to have low back pain even though they're exercising, but the severity and the actual functional disability from this back pain can be significantly reduced with exercise. Acupuncture, craniosacral therapy, osteopathic manipulation, and other manual therapies can be helpful as well during pregnancy-related back pain. There were some recent studies that had come out, more recent than that Cochrane review, that showed 30% of, sedentary women have a 30% higher chance of developing back and pelvic girdle pain than women who are active. And this was a study done in 2019. There was a meta-analysis published in a European Journal of Pain in January of 2018 that looked at 7 randomized control trials that actually did reduce the risk of low back pain. So there are some newer studies out that do show a reduction in low back pain risk with exercise. Physical therapy, when we talk about physical therapy for low back pain, often it's, well, what type of physical therapy? What are we doing in physical therapy that can be effective? And a recent study just published last month in February 2020 showed that both stretching and stabilization exercises can be effective at reducing pain and improving balance in pregnancy. So pelvic girdle pain related to pregnancy is kind of a separate entity, or so we like to think about it that way. The pelvic girdle itself is composed of the pubic symphysis in the front and the right and left SI joints. And pain in these areas might not necessarily be from joint laxity itself, but maybe that there's this asymmetry in the joint laxity, that one is a little bit more lax than the other. In general, this is pretty self-limiting in the sense that the majority of patients, close to about 90%, will improve by 3 months postpartum, but there are 1 to 2% that remain symptomatic at about a year postpartum. So it's also very common to recur in subsequent pregnancies. So if you had it in one, you're likely to get it in your subsequent pregnancy. The presentation can be highly variable. It can be stabbing, dull, burning, shooting. It can be in the front or the back, in the sacral area or the pubic symphysis. There's no distinct nerve root distribution. It can come on really any time in that second trimester and last through the majority of the third trimester. Patients may purposely try to avoid hip abduction and adduction to decrease their pain, and it can certainly alter gait. Some of the clinical exam maneuvers that we use to look at these patients are the Faber, which is femoral abduction and external rotation, to look at both the hip joint as well as the SI joint, which is this picture on the left, and then the Gainsland's maneuver, which is this picture on the right-hand side, which looks at more SI joint pain. If they have pain with this maneuver and are having pain in that low back, it could be more indicative of an SI joint issue. Again, we don't do a ton of imaging during at this time. If we want to get x-rays, it's usually just done that in the postpartum stage, and if we're more worried about something during pregnancy, it would be an MRI. Treatment for these is difficult. The stabilization exercises are, again, there's some mixed data on it. This study done again in the European Journal of Pain in 2018 looked at a meta-analysis of stabilization exercises and randomized control trials for exercising and for specifically pelvic girdle pain, and it showed no protective effect of exercise on the pelvic girdle pain. It did, as I mentioned in the slides for the low back pain, show that it did have an effect on severity of lumbopelvic pain and sick leave. So it did decrease the severity of the pain and sick leave. There's some question as to whether or not pelvic realignment, kind of a stabilization device, may be helpful. The study done in 2018 had showed that this picture here on the right is actually from that article where they show this realignment device being done while doing these exercises right from basically the next day after delivery, and it showed decreasing pain in the immediate postpartum period, but really no differences seen at 13 weeks between those who did the exercises with or without the device. Just a quick couple slides here specifically about pubic symphysis diastasis or rupture. The diastasis is defined as a separation of the symphysis greater than 10 millimeters, and there's a number of things that can perhaps increase your risk of having this. Multiparity, large babies with fetal macrosomia, precipitous labor, very powerful contractions, and having previous pelvic pathology or trauma. The incidence is also it's variable. It can be from 1 in 300 to 1 in 30,000, depending on which articles you read. So how does this present? There's a lot of pain with ambulation. There can be some urinary dysfunction and some pelvic instability. Imaging is not always that helpful in the sense that the degree of separation of the diastasis doesn't directly correlate with the severity of pain. So just because they may have a very widened symphysis, it doesn't mean that they're going to have horrible pain and vice versa. The treatment is also a little bit controversial. There are some treatments that say weight-bearing immediately with physical therapy can be helpful. Some say non-weight-bearing with bed rest can be helpful. Physical therapy, and then perhaps a pelvic binder to help with this. Moving on to diastasis recti abdominis. This is when the muscle bellies of the rectus abdominis are separated by a gap of greater than 25 millimeters in 2 or more measured areas, and typically these areas are measured at the umbilicus and then 4.5 centimeters above and below. The linea alba thins and widens and can cause this separation to happen. It doesn't have the same risk as a true herniation, so there's really no real incidence of having bowel incarceration with this type of issue. It can lead to, however, altered trunk mechanics, some impaired pelvic stability, and changes in posture, in addition to having a very unpleasant cosmetic effect for some women. These changes in the lumbar, in the trunk mechanics and the pelvic stability can put the lumbar spine and the pelvis at more increased risk of injury. Like some of the other things that we had talked about earlier, time can be helpful. In most cases, about 50 to 60% will resolve by 6 weeks postpartum, but as you can see, 40 to 50% take longer or don't resolve. Physical therapy for this is again mixed. A study done in April 2018 in physical therapy showed that a weekly postpartum supervised exercise program, including strength training of the pelvic floor and abdominal muscles, in addition to daily home training of the pelvic floor muscles, did not reduce the prevalence of diastasis. So there's still some work we need to do in terms of researching what therapy might actually be helpful. And some people are trying to do this by looking at neuromuscular electrical stimulation to help activate the abdominal musculature. And in some recent studies, this has found to to be useful. Surgery can be an option if the other things like time and physical therapy have not been helpful and the patient is still having significant disabilities from this. Pregnancy-associated osteoporosis and transient osteoporosis of the hip are rare but severe forms of osteoporosis. And these patients often have Z-scores of less than minus 3.0. They usually present in the last trimester or immediately postpartum with severe pain. Locations include pain in the hips and lumbar spine, as well as possible fractures in these areas as well. The clinical presentation of these patients who have pregnancy-associated osteoporosis is usually more severe than patients who have who are premenopausal and have idiopathic osteoporosis. They're found to have more fractures, and when you look at the actual physiology of the bone, it shows that there's lower bone turnover activity and can indicate possibly some underlying osteoblast dysfunction in these patients. In a study done in December 2017 by Haji et al., they found some associations between these pregnancy-associated osteoporosis and transient osteoporosis of the hip, along with women who had a lot of dental problems as children, women who didn't have much exercise or sports activities as a child, and who are more sedentary or immobile now as adults. And about nearly a quarter of women who have these issues will go on to have subsequent fractures at a median of about 6 years after this pregnancy. So not all, but a quarter. Treatment of this, there's really no valid therapeutic recommendations right now because there's so few cases that occur. Calcium, vitamin D, bisphosphonates, denosumab, and teriparatide have been shown to have some benefit. And overall, the prognosis is pretty good, but it can have a significant impact on pain, mental state, quality of life, and capacity to work. One study done in this clinical rheumatology study done in December 2019 showed that the average return to employment was about 3.3 years. And lastly, we'll talk a little bit about carpal tunnel syndrome. So this is very prevalent in pregnant women. It ranges from anywhere to 1 to 62%, depending on what you read. It's more common after 32 weeks of gestation, and it's generally thought to be due to the hormonal changes and because there's more fluid retention that occurs in the later trimesters. Gestational diabetes can also play a role. We think that diabetes generally slows down nerve conduction, so this can also have an effect. And this carpal tunnel syndrome can also contribute to sleep problems because it can be worse at night when women are sleeping. It presents just as carpal tunnel syndrome presents in those who are not pregnant with pain, tingling, numbness in the wrists or hands. Like I said, it's worse at night. It's often bilateral, and it most commonly appears in that third trimester. On exam, they may have a positive Tinell's or a positive Phelan's, where when you tap on that nerve or have them in wrist flexion, they will have worsening of their symptoms. Treatment for these women is the same as it would be outside of pregnancy, where we start with wrist braces at night. Sometimes we'll do injections. A one-time injection of corticosteroid in pregnancy is considered safe for this condition. And surgery is rarely indicated in pregnancy because it does seem to be more of a self-limited issue that once they deliver and the fluid retention resolves, their symptoms resolve as well. So with that, I'm going to wrap up and send this over to my colleagues. I found myself on the top of a lot of mountains during pregnancy, and I hope to do it again. So stay active. Tyler, if you could switch over to the next one, thanks.
All right, so I'm Rebecca Kesting, and I'm going to be starting us off. Heather and I are going to be, Heather's going to be on later, but we're going to be discussing understanding and rehabilitating the pelvic floor. Our objectives for today are going to be to understand the location and the function of the pelvic floor, to to talk about pelvic floor dysfunction in athletes and how we can screen for it, to discuss pregnancy and delivery and how they can impact the pelvic floor, and then lastly, how we can rehabilitate the pelvic floor. So what is the pelvic floor? It's a term we hear a lot. Basically, this is a term for the muscles, ligaments, fascia, and nerves that work together. The functions of the pelvic floor are to maintain continence, to support the pelvic organs, provide core stability, participate in sexual arousal and performance, and maintain optimal intra-abdominal pressure. Research by Diane Lee and Paul Hodges, as well as others, show that in an optimally functioning system, the pelvic floor is going to work with the transverse abdominis, the diaphragm, and the deep muscles of the multifidus to create anticipatory intersegmental stiffness of the joints of the lumbar spine and the pelvis before loading occurs. So when we're being physically active, what's the pelvic floor doing? Well, it's going to work as core support so that we can breathe and throw a ball at the same time, or also not leak urine or feces when we're performing impact activities. Looking a little bit at anatomy, the pelvic floor muscles exist in 3 layers that surround the urethra, the vagina, and the rectum. The superficial layer is the perineal layer. It's mostly concerned with sexual performance. The second layer is the deep urogenital diaphragm layer. This is where the urinary sphincter muscles lay. And then in the picture here, you can see the pelvic diaphragm. That's the deepest layer. It's made up of the levator ani muscles, coccygeus, piriformis, and obturator internus. Additionally, the perineal body is a connective tissue area that's between the vagina and the rectum, and it's where many or most of the pelvic floor muscles attach. During birth, muscles that may be torn are some of the levator ani muscles, puborectalis, pubovaginalis, as well as superficial and deep transverse perineal muscles. It's also possible with a larger tear, like a grade 3 or 4 tear, that there might be tearing of the anal sphincter muscles. Additionally, there are nerves in the pelvis. The first 2 layers of the pelvic floor are innervated by the pudendal nerve, and the sacral nerves innervate the deepest layer of the pelvic diaphragm. To note, there are also peripheral nerves that traverse the pelvis to the lower extremity, and just making the pelvis a major junction point. Pelvic floor dysfunction is prevalent, underreported, and misdiagnosed. So there are no studies that look at the prevalence of all types of pelvic floor dysfunction, meaning incontinence, sexual performance, stability, etc. But if we look at one sign or symptom or this type of dysfunction, we're going to get an idea of prevalence. And it's easiest to look at urinary incontinence because it's more reported than others. In a meta-analysis completed by Taxier and colleagues, they found that 36% of athlete women had urinary incontinence. And it was more prevalent for the athletic women in their study than the sedentary women. Tyson in 2002 looked at frequency of urinary incontinence in elite women athletes. 51.9% of these women reported incontinence, and only 3.3% of them had discussed the issue with their doctor. When looking at primary care providers and their familiarity with these conditions, there was a study done that they gave providers case vignettes looking at patients with these conditions, and they were largely unable to recognize pelvic floor diagnoses. When they recommended treatments, their proposed interventions were not supported by evidence. Typically, the physicians were looking to treat it as a medical diagnosis rather than recognizing there's a musculoskeletal component involved, and they often did not refer to pelvic floor physical therapy. All this to suggest that it would not be uncommon for an antepartum athlete to have an undiagnosed pelvic floor dysfunction when they come to see you in their office. So what would we look for in an athlete? So there's no existing international agreement on terminology for pelvic floor dysfunction, and this lack of uniformity is because there's a lot of different disciplines and providers that treat different parts of pelvic floor dysfunction, so you're going to notice some overlap in terminology. But if the pelvic floor is weak, tight, or uncoordinated, we may see urinary incontinence, anal incontinence, sexual dysfunction, voiding dysfunction, defecatory dysfunction, pelvic pain, or pelvic prolapse. Additionally, there may be some complaints that sound musculoskeletal in nature, but they may also have a pelvic floor component. So if, we looked at some of our subjectives that we heard from pelvic floor patients, and they may see things like, I get my hamstring pain when I have a bowel movement. I have hip pain and I need to pee whenever I have sex. I have pain with sitting, but it goes away when I sit on the toilet. I have tailbone pain after I poop. If I take a bar class and it's really difficult, I'm going to have to pee every 30 minutes afterwards. It makes me feel like I have a UTI. Athletes can present with multiple risk factors for pelvic floor dysfunction depending on their sport. Hartman and Starton identified multiple possible causes for pelvic floor dysfunction, and of those, the following would be common among athletes: faulty biomechanics, falls with landing on a sacrum or coccyx, lumbopelvic or hip injuries, repetitive movement injuries seen with high-velocity sports in altered postures, abnormal chronic holding patterns, dysmenorrhea, and nutrient deficiency. Specifically looking at nutrient deficiency, in a study by Bow and Borgen in 2001, they were looking at elite athletes with disordered eating, and they found that they had higher stress and urge urinary incontinence than their healthy athlete counterparts. Further, overtraining can lead to incontinence. According to a study by Vitten in 2011 with young, healthy female athletes completing intensive sport, which they defined as anything greater than 8 hours of activity of a sport in a week, they had increased likelihood of anal and urinary incontinence. The authors described potential factors contributing to these symptoms being inadequate abdominal pressure regulation, stress injuries to pelvic fascia, pelvic floor muscles, or pelvic ligaments, changes in connective tissue or collagen structures in the pelvis. So as we know, many athletes like marathoners, dancers, gymnasts, anybody who does like cross training may easily partake in more than 8 hours of physical activity in a week. Additionally, a study by Tyson in 2002 showed that the activity most likely to provoke leakage was jumping. They hypothesized this was because the high-impact physical activity where both feet are off the ground at the same time involves abrupt, repeated increases in intra-abdominal pressure, which may increase rates of urinary incontinence. So increased hours or overtraining and lots of jumping may increase prevalence of incontinence.
Thank you, Rebecca. So it's Heather on now. How can pregnancy and birth impact the pelvic floor? Not only is there a good probability of pelvic floor dysfunction in the athletic population, but adding pregnancy and birth can also increase the likelihood. In fact, vaginal delivery can be considered equivalent to a major sport injury, and cesarean delivery is a major surgery, but they are often not given the same attention concerning prevention or treatment. So, pregnancy itself is a risk factor for pelvic floor dysfunction. Increased intra-abdominal pressure due to the growing uterus, the change in the axis of the lumbar spine, and the increased laxity of joints in pregnant women from hormonal changes may all be predisposing factors. Having a cesarean delivery does not necessarily prevent pelvic floor dysfunction, as the pregnancy itself and elements of pregnancy can be contributors. In fact, in a study of 94 nulliparous women examined for a prolapse at 36 weeks antepartum and 6 weeks postpartum, 32% of those who sustained vaginal delivery and 35% who had cesarean during their delivery had developed a new prolapse. Also, in a cross-sectional study by Johansson et al., 1 in 5 primiparous women suffered from anal incontinence 1 year after delivery, and the main predictor was anal incontinence in late pregnancy rather than mode of delivery. And then you have to consider the marathon, that is labor, with duration of the first and second stages, cesarean versus spontaneous vaginal versus instrument-assisted vaginal delivery, perineal lacerations, episiotomy, weight of the newborn, and advanced maternal age, all being factors in the development of pelvic floor dysfunction. Many studies using different techniques have demonstrated neurogenic and structural damage to the pelvic floor muscles and sphincter muscles as a consequence of vaginal delivery. The main pelvic floor disorders postpartum are urinary incontinence, anal incontinence,
and pelvic organ prolapse. The second stage of labor is defined as the time period from complete dilation of the cervix to the birth of the infant. Prolonged second stage of labor has been associated with risks of adverse maternal outcomes such as nerve injury, urinary incontinence, and levator muscle injury. Pressures generated by pushing are 3 times higher than the tissues would normally tolerate for any prolonged time. The long duration in the stretched position, as shown in the larger red circle, the stretched position versus the normal smaller circle of the opening, the levator hiatus, increases the likelihood of levator ani muscle injury and edema. The pudendal and the pelvic nerves lie on each side of the birth canal within the muscles that are directly under the baby's head. Because they are so close to the baby's head, these nerves are especially vulnerable to the pressures of labor and can undergo a compression or traction injury. The nerve injury can lead to muscle weakness and pain, which can result in incontinence and/or prolapse. In an observational cohort study by Dietz and Bennett in 2003, duration of second stage labor correlated with an increase in pelvic organ descent. Further, Sheik and Dietz in 2010 noted increased second stage of labor is associated with increased levator hiatus, that area between the two sides of the levator muscle postpartum. Both studies demonstrating changes in biomechanical properties of supports, structures which may lead to urinary incontinence and pelvic organ prolapse. Another factor in labor and delivery that can affect the pelvic floor is if instruments are used to assist. Research by Memon and colleagues in 2015 suggests that the prevalence of levator ani avulsion tears in birth is 2.74 more prevalent with forceps assistance than vacuum assistance. When assessing self-reported symptoms through a questionnaire, there was a significant increase in prolapse-related symptoms by the women who had forceps-assisted deliveries. In a different prospective study in 2001 by our young colleagues, they followed women for up to a year after birth. At 3 months and 1 year, women who had a forceps-assisted delivery reported increased incidence of incontinence than women who had spontaneous and vacuum-assisted deliveries. And at 1 year, their symptoms were more severe. All this to suggest that forceps-assisted delivery may affect the structure and function of the pelvic floor after delivery. So the pelvic floor muscles experience change during delivery, from something as simple as overstretching to possible tearing, cutting, and avulsion. Injury to levator ani muscles with birth is cited between 13 to 36% of women. Injury to the levator ani muscles is associated with pelvic organ prolapse and urinary incontinence. Levator defects are also related to fecal incontinence. Pelvic organs are supported by the levator ani muscles and create high-pressure supports similar to the sphincters around the urethra and the vagina. Sometimes the hiatus is larger as a result of muscle injury. Together, the static structure of the pelvic floor muscles and ligaments combined with the contraction of the muscles creates enough force to counteract abdominal pressures. If the structure or muscles are damaged, the loads of abdominal pressure may exceed the strength of the pelvic floor, and they may be stretched or broken, and prolapse may occur. In addition, as a result of these changes, there can be pelvic pain. In a meta-analysis by Manresa et al. In 2019, pelvic floor pain and dyspareunia are more common and last for a longer duration after second-degree lacerations and episiotomy, with the highest report of perineal pain in women who had undergone an episiotomy. How can we assess for pelvic floor dysfunction in our patients? So now that we have seen that athletes have a risk for pelvic floor dysfunction and that pregnancy and delivery only compounds that risk, what can we do? We can assess. As we know, most of our diagnosis is made through the subjective. The right question is important. We can't just ask about changes, as the individual may believe dysfunction is normal. Instead, we need to know what their normal is and what their patterns are. So some of the questions we can ask are, do you leak with coughing, sneezing, or jumping? Do you have pain with sex or inserting a tampon? Do you hesitate once in position for your bowel or bladder elimination? If someone answers yes to any of the questions on these slides, they need to be referred to a pelvic floor specialist. So this slide is so you know what normal is. Normal bladder emptying should be about every 3 to 4 hours, totaling 6 to 8 times a day, including the possibility of one nighttime void. An individual should feel empty afterward and have no pain with urinating. Also, the voiding should be effortless, no pushing or straining. Leaking is never normal. Bowel movement norms are a little more variable, occurring between 3 times a day to 3 times a week. Know that consistency is key, with the ideal being a stool that is formed, soft and easy to expel, such as types 3 and 4 on the Bristol stool chart. So, we know dysfunction is common. The likelihood of dysfunction after birth is increased. There has to be an element of rehab because it's a major injury. The message postpartum individuals often hear is 6 weeks, you're ready to move on. But the reality is the individual may have suffered at the minimum a severe muscle strain, but there may also be tearing, avulsion, denervation, etc. 6 weeks would not be the return to play guidelines for any other muscle group with these injuries. In fact, in a systematic review of hamstring tendon repair by Belk et al. In 2019, it was determined that the mean time to return to sport was 5.7 months. A postpartum patient that required stitches after vaginal delivery would be considered someone who had muscular repair. There is not a lot of high-quality research on physical therapy and pelvic floor rehab, but more and more is coming out every day, and from what we have, it demonstrates its efficacy. Manual techniques have been found to be beneficial for edema control for the limbs, and we can kind of extrapolate for the pelvic floor. So we do know there is significant edema post-vaginal birth. Tan in 1999 continued to see pelvic floor muscle changes and signal intensity via MRI at 6 weeks postpartum, with return to normal parameters at 6 months. Manual therapy is beneficial in treating pelvic floor pain, and a study of dyspareunia, painful intercourse, Garretti et al. In 2019 performed a randomized controlled trial in which the treatment group received intravaginal massage as well as TENS and strengthening compared to controls who received no treatment. The treatment group demonstrated decreased pain and improved scores on the Female Sexual Function Index. Dyspareunia is often correlated with pelvic floor muscle overactivity and trigger points, hence the incorporation of manual therapy techniques. Just like scar massage is used post-op for orthopedic surgeries, in a case study by Morrison et al. In 2015, myofascial release techniques were used on a patient after perineal trauma that resulted in scarring and dyspareunia with symptom resolution at the 6-month follow-up. Most women do not know how to properly contract the pelvic floor. In fact, Bump et al. In 1991 found that only 49% of women performed an ideal contraction that created a good urethral closure without Valsalva. And a full 25% of women actually performed technique that could potentially increase incontinence with Valsalva and bulging of the pelvic floor. Hence, the manual techniques are great for teaching proprioception, letting them feel the sensation. So just saying to women with uncomplicated deliveries, go do some Kegels and your pelvic floor will be fine, actually might not be enough. Guided pelvic floor muscle strengthening is important for treatment of incontinence and prolapse, both as prevention and rehabilitation. In a blinded randomized controlled trial by Braken in 2010, pelvic floor muscle training significantly improved pelvic floor muscle strength and muscle thickness, reduced muscle length and area of the levator hiatus, in addition to lifting the position of the bladder neck and rectal ampulla. Hence, pelvic floor muscle training is changing muscle morphology, working in the same way as strength training of general skeletal muscles, which they are. For prevention, a 2017 Cochrane review concluded that women with no prior history of incontinence instructed in pelvic floor muscle training prior to pregnancy were less likely to report urinary incontinence in late pregnancy and up until 6 months postpartum. For rehabilitation, a cross-sectional study by Johansson et al. In 2014 found that women with incontinence 3 months after delivery who were instructed in pelvic floor muscle training were 40% less likely to report incontinence at 12 months compared to women who did not receive treatment. And the more intensive the program, the greater the effect. Several randomized control trials have also found that pelvic floor muscle training can actually reduce pelvic organ prolapse, stage, severity, and symptoms in middle-aged women, and it is therefore recommended as a first-line treatment. So, Near normal position and strength of the pelvic floor happens at about 6 months on average. No, not 6 weeks. We can infer what we know about healing, progressive loading, and other exercise concepts to guide us in the postpartum patient. As Julie said before, Dr. Hahn, the World Health Organization's guideline of physical activity recommends that adults engage in at least 150 minutes of moderate intensity aerobic activity throughout the week, and these can be in bouts of at least 10 minutes. Muscle strengthening should be done 2 or more days per week. And then they further state that postpartum women may need extra precaution and should seek medical advice before striving to achieve these recommendations. The American College of Obstetricians and Gynecologists released a statement in 2002 acknowledging the physiological changes of birth and pregnancy remain 4 to 6 weeks after giving birth. They state that there are no studies to show that rapid return to activity level has adverse effects, and that the resumption of physical activity can reduce the symptoms of postpartum depression. However, only if the level of activity reduces stress rather than increases stress. While these parameters are broad, we can conjecture that if returning to a high intensity of activity is resulting in incontinence or pain, this demonstrates stress to the system. A more gradual progression of activity and assessment by a PT would be appropriate. In a recent review of current best evidence and expert opinion summary from Goom, Donnelly, and Brockwell, 3 physios in the UK, looking at return to running postnatal guidelines, it is recommended 1. Postpartum patients should be assessed and treated as necessary for pelvic floor dysfunction. 2. It is best to follow a low-impact exercise timeline for the first 3 months. 3. Signs, symptoms of pelvic floor dysfunction with exercise indicate you are not ready for the activity and to follow up with a medical professional. 4. Return to impact activities would be more appropriate in the 3 to 6 month postpartum period. In summary, we have reviewed what the pelvic floor is and what dysfunction might look like. We have discussed how pregnancy and birth can impact the pelvic floor. We discussed how, as providers, we need to screen our patients for dysfunction. And we discussed how pelvic floor PT can improve symptoms with manual therapy, strengthening, and progressive loading. Thank you so much.
All right. Great job, guys. That was pretty awesome. So we're just going to kind of close out the evening. I want to go over some of the questions that we had coming in. Most of them were from Dr. Hahn's talk. The first one I can field, the recommendations about equestrian activities. So, the thing about it is you got to think about safety first. So there's, under equestrian activities, there's a whole bunch of different kinds. There's the show jumping versus, saddlebred showing versus dressage. There's a lot of different hunter jumper. There's a lot of different types of equestrian activities. And so some of them are going to be more risky than others. Something like dressage is going to be a heck of a lot less risky than something like show jumping, just in its very nature of the sport. But you got to think about the other consequences too, just that it is a horse that it's a large animal that has its own mind and own will, and accidents do happen. And so it's important to think about that, and especially the point in your pregnancy where you are, first trimester, the baby is very protected within the bony pelvis. After that, once it starts coming out, that's the point at which it's a lot more vulnerable. And so being able to think about that in relationship, definitely, the relationship with the horse, for those horse people in the audience, that the relationship with the horse is often therapeutic. But perhaps, for some of the pregnancy, thinking more about lunging the horse and grooming and keeping them in shape for after delivery would be a lot safer overall, but still maintaining the health of the horse and your relationship with them. So that would be, those are kind of my recommendations. We don't really have evidence. It really comes down to just pure safety first. So, yeah. So next we're going to go to another question. This one I'm going to toss over to Dr. Julie Hahn. If elite athletes are required to train at 90% or less of VO2 max, how are those running in US ATF or US Open able to compete with the goal of winning and participating at 100%? That's actually a really great question. I'm going to pass that over to Julie.
Yeah, good question. So remember that the current guidelines are actually not heart rate based, and so that specific study that I was sharing with you guys was just a small study of, I think, 6 Olympians, and so the conclusion of that study was just that a heart rate of 90% or greater may put you at a greater risk of having effects on the fetal heart rate. So recall that in that study, they saw some fetal decelerations at a higher heart rate, but, there was no effect on outcomes in any of those 6 Olympian athletes. And so, we don't use heart rate as guidelines for exercise, so that's not a requirement. And also, for those elite athletes, such as the example that I gave of Alicia Castaneda, she actually finished last at the prelims. Her goal wasn't for winning, and so I think it's a discussion that you have to have between the elite athlete and the physician. What is your actual goal during your pregnancy? If you want to continue to compete, is it to win? Most likely not. It's probably just to maintain your fitness at a safe level and educating them on the risk factors and the warning signs to watch out for. So those things that we touched about. So while they're continuing to exercise at a vigorous, high-intensity level, they need to make sure that they're, not having any symptoms of dizziness or headaches or shortness of breath, vaginal bleeding, contractions. I think that's the best guidelines that you can give to your elite athletes.
That's awesome. What would you say, this other question, the 150 minutes per week exercise guidelines, is this through all 3 trimesters or does it vary? So those guidelines are for all 3 trimesters of pregnancy. Again, any variation of that exercise will be based on any risk factors or warning signs that they might have during exercise. That will be the most important thing to watch out for that might change that guideline. So they may not be able to tolerate 150 minutes of exercise a week. Okay, yeah. Next one is for Dr. Lauren Borowski. So when you see patients in the office who are recently postpartum, what sort of things are you looking out for when you should send to pelvic floor therapy? Do you have specific criteria or are there kind of red flags that perk? And is there a time frame in which you give them a chance to recover postpartum, or would you send the sooner the better?
I think the sooner the better, first off, because I think, as Rebecca and Heather showed us in their presentations that most women will benefit from some pelvic floor assessment at least, and then some rehabilitation in this area. I end up thinking about the pelvic floor a lot if women come to me with persistent low back pain or any sort of pelvic girdle pain as well, because I think that the pelvic floor musculature assessment should be part of that exam, and I want to send them to someone who, like Rebecca and Heather, who are specifically trained in this pelvic floor therapy evaluation. So I can do, a lot of the SI joint and low back pain and pubic symphysis stuff, but I don't personally assess the pelvic floor like they have been trained to do. So I tend to pull the trigger pretty quickly when women who are postpartum come to me with, low back pain or pelvic girdle pain.
And probably also any kind of incontinence too.
Exactly. So certainly, that's one of the questions that come when I ask them about these, when they come in with those complaints. That's certainly one of the questions as a screening. Do you have any leakage of urine when you sneeze, you cough, you run? All of those things can improve with some time, but I think that a pelvic floor therapy evaluation to try and help improve them or perhaps hasten those symptoms can be really beneficial.
Do you ever start with imaging for these women if they have numbness or any kind of pelvic pain? Do you start with imaging, or do you start more with clinical assessment and therapy-based?
I think it depends sometimes on the degree of pain as well. I certainly start with physical therapy pretty quickly, but depending on where they're painful, how painful they are, certainly, one of the things I had mentioned during my talk was this, very rare very rare osteoporosis that's associated with pregnancy, and not that that's necessarily high on my differential, but it's certainly something to keep in mind. And so, certainly things like stress fractures can happen in and around pregnancy, particularly, in women who may have had some questionable bone health to begin with and who were continuing to exercise as much. So still things that I think about in my non-pregnant athletes as to reasons why I would get imaging.
Excellent. Thank you so much. All right. Well, we've got about 2 minutes to wrap it up. If anybody else has any questions, please feel free to submit them. Otherwise, I'm going to thank everyone, Dr. Carter, Dr. Hahn, Dr. Borowski, Heather and Becca, our pelvic floor specialists. They are pretty incredible, and so we learned a lot from everyone, but I think it was definitely a special treat to have you guys here, Heather and Becca. So with that, I will say good night to everyone. Stay healthy, wash your hands, don't touch your face, and have a great night.